Thank you and welcome. Thanks, everyone. So I'm Dr. Bégué from Pediatric ID here at Kapiolani and JABSOM, and we're going to be talking about different forms of the forms of hepatitis, right? I have no conflicts of interest. So how did we get to this point? Well, it's been a long journey actually to get here, and basically, I guess we need to talk before January 5, this past month, uh, and after January 5, right? Before we had a sort of well-structured system where all the societies would come together with CDC, and then they would put their thoughts together, and they would come out with a joint recommendations about vaccinations. And then starting actually during last year, but then more so this past month, they decided to start to move things around and basically make some routine vaccines uh, less of a recommended one. Uh, and actually, there's a talk now that in the next session, when they have the next meeting, they will be basically saying that all vaccines are optional and that every vaccine should be discussed with between the parents and the doctors and decide if they want to do it or not. That's creating huge problems. So the idea that I was presented with was that, if we stop uh, we already were seeing a decrease in vaccination. If this gets worse, then vaccine preventable diseases are going to start coming back. And are we ready to tackle them since some of them have not been around for 20, 30, 40, 50 years, and some of them may have never seen them. So the idea is to go back over how bad this could get and what to do about it in case you start to see this kind of problems. Uh, as I told Dr. Luker, yeah, there's really not much structure on this presentation because we should not even be talking about this. I will mention what I think may be pertinent for you to pay attention to know. And if there's any question, just feel free to ask the question or make a comment, and then we'll talk about that. So this is more a conversation than a formal one-way presentation. Um, Now this is not moving. Uh, oh, here we go. So we will talk about how did we get to this point, when to suspect these diseases, how to test for them, which is, I think, something that we need to refresh about, how to treat them, those who are treatable, and especially how to control them, which is where you guys may have a special role. Uh, the objectives we already talked about. So let's start with each one of them. And there's no specific order, but I think I'll start with hepatitis B, one, because that's the most elaborate of all of them, the one that has the most rules, and because it's the one that we give at birth, right? One thing I have to say is that there's not much things in common for these three diseases, hepatitis A, B, and C, except that they all cause hepatitis, and clinically they can be difficult to distinguish from each other. They're actually different viruses, they act completely different, and they have different approaches, but they all cause hepatitis. And I don't need to explain to you what hepatitis looks like. You know that very well. The clinical syndrome of hepatitis with jaundice and malaise and coluria and so on is well known to you. But hopefully you can figure out which type of hepatitis this patient is having. So hepatitis B is a DNA virus. It can cause chronic or acute infection. Chronic and acute infection is what you may make you aware of the problem, but chronic infection is actually what the most significant clinically is. It's different between children versus adults, and adolescents fall sort of like on the adult side, in the sense that chronic hepatitis is more common in children. Acute hepatitis B is rare in children, especially infants, uh, but they usually go into chronic. Adolescents and adults are usually symptomatic, but they usually do not go into chronic. As you may remember from medical school, hepatitis viruses by themselves are not hepatotoxic. Uh, it's the immune response to the presence of the virus what is really hepatotoxic. So those who have the most symptoms, which are fighting the infection the most aggressively, tend to clear it more frequently than those who don't. So children who are usually asymptomatic tend to be chronic. Adolescent adults who are usually symptomatic tend to be acute, but still some of them may be chronic, right? Children, about 90% of those exposed perinatally will become chronically infected, while adolescents and adults, only about 5 to 10% of those who are acutely infected will become chronically infected. Interestingly, it's transmitted mainly by blood, but also by many other secretions. So it's not exclusively blood. Blood is a big one, obviously, when it comes to talking about transmission of hepatitis B, but it's not the only one. So in the past, about 50% of children would be infected perinatally, and about 50% would be just by living in a household where there is someone who's chronically infected. Well, to fix that problem, back in the 70s, 80s, they developed a hepatitis B vaccine, which is one of the most successful vaccines we have, has almost no side effects, and it does have almost 100% effectiveness. It's very safe, very effective. The traditional regimen is 3 doses. The first is the initial dose, then 1 to 2 months later, and then 4 to 6 months later. And there's many rules about how to do when people don't follow this one, right? Besides the vaccine for babies at birth, perinatal exposure, there is hepatitis B immune globulin, or HB, right, which can be given under some circumstances that we will mention later. Normally, children, when they get the 3 doses of the vaccine, they don't need post-vaccination titers, right? If someone presents late, so they're supposed to come back in 2 months to get the second dose, but they don't come back for 6 months or 12 months or whatever, you don't need to restart the series. You just give the next dose. As long as you have good documentation of the first dose, you just give the next dose, and that counts as a second dose, and then you follow with the third dose, and so on. If it's given early, they're supposed to come back in 2 months, and they come back in 2 weeks, and they get the vaccine in 2 weeks, then that doesn't count, and that dose needs to be repeated. I'm sure you all know the vaccine only has surface antigen. It's a purified form of the surface antigen, so it only elicited surface antibody. So people who are immune due to vaccination should only have surface antibody. If they have any other hepatitis markers, then that person has been exposed to hepatitis B. And the other thing to remember, and I read this someplace, 50% lose antibodies after 10 to 20 years, and I have seen many numbers thrown, but the main point is that a lot of people who get hepatitis B vaccine do respond to the vaccine well, but in the next few decades, they lose the antibodies. That does not mean that they lose protection. They're still protected. It's just that they're not showing the antibodies because they don't have continuous exposure to the virus. They don't keep showing the antibodies. Eventually, their cells stop making the antibodies, but the cells are still there. And if they get re-exposed, they will come out, the antibodies will come out, and they will be protected. Of course, there's no way of knowing if someone gets the vaccine and 20 years later is surface antibody negative. You don't know if it's because never responded to the vaccine or because they lost the antibodies, but they are protected. And that's why you need to re-immunize them and see if now they make antibodies or not. Healthcare workers, they get immunized if they have not been immunized in the past. And once you show you have antibodies, then for the rest of your life, you don't need to worry. If 40 years later you get exposed to a needle stick and you don't show antibodies, still very good chances that you are protected because you had antibodies shown before. Now, diagnosis of hepatitis B is sort of confusing because there's too many markers. We'll see how A and C have only few, but hepatitis B have a lot of markers, right? The main one is the surface antigen and the surface antibody, right? They do not coexist. So either you have surface antigen or you have surface antibody, but you don't have both of them. In other words, if I test you and you have surface antibody, then I don't need to test you for surface antigen because I know that you're already protected, right? If I test you and you have surface antigen, I don't need you to test you for surface antibody because there's no way you can have surface antibody on top of surface antigen. So either you are infected or you're not infected. Surface antigen means infection. During acute infection, lasts only for a few weeks and then it goes away. In chronic infection, remains with you throughout the whole infection for years and years, right? And again, surface antibody means immunity. As long as you have surface antibody, now you're immune. Sometimes surface antigen disappears and it takes a while for the surface antibody to reappear. And there is a period there, which is somewhere between 2 and 4 weeks, in which you may not have surface antigen, you may not have surface antibody, and yet you may be infected. That's where your core antibody helps to figure out, right? And for core antibody, there's no core antigen, by the way, it's only core antibody. Core antibody comes in two flavors. It's either IgM or it's total. Total meaning IgM plus IgG, right? Of course, if you have total positive but IgM negative, means that all you have is IgG, right? Because that's the only other type of antibody you could have. If you are total positive and your IgM is positive, means that you are acutely infected, right? So a total positive with a negative IgM means that, yeah, you were exposed to hepatitis B, but this was way in the past, and you're not actively infected now. While a presence of an IgM means that you are actively infected, and the fact that you're not showing antigen or antibody, surface antigen or surface antibodies, because you're in that window period, which again, in the world of hepatitis B, which evolves over decades, 2 to 4 weeks is nothing, right? So it's unusual to have that scenario. But normally those get included in the panels to make sure you can definitively decide at what stage your patient is. Now, those patients who are infected, so they have surface antigen, then the next thing to check is the E antigen. The E antigen goes with an E antibody too, right? And the E antigen, on top of telling you if someone is infected, tells you the level of replication. In other words, how aggressive the infection is. Is it a low level of infection, which goes with less contagiousness and less likelihood to progress to liver disease? Or is it a high level of replication, which is more transmissible and is more likely to lead to chronic liver disease? So that's why you want to check your E antigen, right? And also the E antibody, because if you have E antibody, means that you will never have E antigen. So put you at a different category as opposed to those who have E antigen positive. And just so you know, there is a DNA by PCR that you can do, quantitative, and can replace to a good degree what E antigen is telling you. It's more expensive, it's less widely available. So my advice to you is to not, well, if you have access to it, you can order that. But if you don't know, that's probably more something that we in ID will use, and probably you will not get to use too much. So when you put it all together, then you can have some common panels that you use to test your patients, right? On the left, upper left, there's the post-vaccination response. If you have a baby who's born to a mom and you give them the vaccine and you want to make sure they did respond well to the vaccine, then you would check your surface antibody. And at the same time, if there's a high-risk situation, you also want to check your surface antigen, right? To make sure if the surface antibody is positive, the patient responded well, is protected. If the surface antibody is not there, but the surface antigen is there, means that the vaccine did not work and the patient got infected. Too bad, which happens sometimes, right? Then on the left bottom, you have screening. Still, there is a recommendation from CDC, and I'm saying still because it could change any moment, that every adult should know their hepatitis B situation at least one time, should be tested at least one time in their lifetime, right? And the screening is a triple panel that includes surface antibody, surface antigen, and core antibody total, right? So that way you can know if someone is infected with hepatitis B or is actually protected from hepatitis B, and at which situation it is. Is this a chronic infection? Is it an infection that happened a long time ago? Is it an infection that is happening now? So in case, as I mentioned before, that surface antibody, surface antigen are negative, then you can do the core antibody total, and if positive, then you may have to follow with the core antibody IgM. And then on the right is the so-called acute hepatitis panel, which people love. And I always ask them, so what is in the panel? And very few people can tell me what is in the panel, right? So this is an acute hepatitis panel. So it should be used only for those who have acute hepatitis. If you have a patient with acute hepatitis, having jaundice, having malaise, having coluria, having elevated liver function tests, then this is the panel that you would use, not the ones on the left, but the one on the right. And it's targeted to find, to detect what is the cause of this acute hepatitis. For hepatitis A, uses the IgM, and we'll talk about that later. For hepatitis B, uses surface antigen and the core antibody IgM, because those are the ones that show if you are infected now and if it's a recent infection. And for hepatitis B, uses the core antibody. By the way, at any point, feel free to refer patients to ID or call us, right? If you get all these many different markers and you're unsure about how to interpret them, always give us a call and we can discuss them. And if we think this is a chronic infection, chances are we're going to tell you, send the patient over, because now everything will change. You guys can handle the testing and this survey and the screening. But probably if someone has chronic hepatitis, that's when we need to get involved. And a common scenario for you is going to be perinatal hepatitis B, right? By the way, hepatitis B is mainly perinatal, right? It does not happen, sometimes, but rarely, very, very rarely happens in utero, but that's very, very rare. The vast majority of cases of infection in neonates will happen from perinatal hepatitis B. Exposure to hepatitis B perinatally. Why is that important? Because then it gives you a point where you can intervene and you can prevent transmission, right? And these are the rules about how to handle those, right? If the mom is surface antigen positive, meaning she is infected with hepatitis B, and is E antigen positive, meaning that she's replicating very highly, which can also be reflected by a high DNA, more than 200,000 international units per ml, then that mom should get antiviral treatment while she's pregnant. There's some medications that suppress the replication of the hepatitis B virus. And the reason is to try to lower the chances that the baby will get infected. A baby, if mom is E antigen positive and mom is not treated, the chances of transmitting to the baby is 90%. If mom is E antigen negative, the chances is 10 to 20%. That's why we worry so much about the E antigen positive moms on top of surface antigen. So we would give antivirals to the mom. The baby, we would give vaccine plus HBIG. So we'll do everything. And then we would need to recheck that baby to make sure it responded well to the medication and did not get infected by doing a surface antigen and surface antibody at 9 to 12 months. Not before 9 months, because that's how long it may take to show the surface antigen. And it should be 1 to 2 months at least after the last dose of hepatitis B vaccine. By the way, hepatitis B vaccine, those countries who don't have HB can only use hepatitis B vaccine when moms are positive, and then the baby, for surface antigen and the baby is born. Vaccine alone is about 80-something% effective. Adding HB increases that to like 98%, right? But there's always the chances 1 to 2% that even though you do everything right, that baby may get infected. That's why you want to check that baby at 9 to 12 months. On the second row is a mom who is surface antigen positive, but E antigen negative, so the level of replication is less. It can be expressed by DNA less than 200,000. Here, because mom is surface antigen positive, the baby will mom doesn't need to be treated because the level of replication is low, but the baby will need vaccine and HB, and the baby you need to check the response at 9 to 12 months. If the mom is surface antigen negative, which is the vast majority, then you don't need to treat, obviously, the mom, and the baby only gets the vaccine at birth, and there's no need for post-vaccination testing. And this is the vast majority of patients you will see, but occasionally you will see some on the upper side. Why we insist on that maternal vaccine, I'm sorry, that baby vaccine at birth comes from basically this graph. And that's the thing that is being disputed now, right? Uh, and these graphs represent acute hepatitis B cases in the U.S. over the years, right? The blue line, and then the green line is less than 12 months, so baby acute hepatitis B, how it progressed over the years. And then the yellowish line is the perinatal hepatitis B cases, which, I mean, have not been checked separately until very recently. But the three periods you want to see is 1984, which is when they recommended testing high-risk moms. Always, every time CDC has tried to go after high-risk groups, has failed because it's hard to define high-risk groups, and people don't necessarily have to disclose their high-risk conditions for many reasons. And it's up to them. If they don't want to tell us something about their lives, it's completely up to the patient. So it never works. And then in 1988, they started testing every mom against hepatitis B using surface antigen and treating only those babies who were positive. That's the second arrow, red arrow that I'm showing there. What happened? Well, not much. There was some decrease. Better than testing only high-risk moms was testing every mom and giving the vaccine. But actually, in 1991 is when they finally moved to, well, test every mom, but give the vaccine to everyone at birth, right? And that's when finally, after 1991, which is the third arrow, you can see a drop in the figures. And then finally, we get to this point. Before, we used to have 25,000, 30,000 cases of acute hepatitis B in the US. Now the numbers are, I mean, minimal, less than 100. And basically, baby hepatitis B has disappeared. So if we stop doing, so it's not like we don't want to do what they're telling us, it's that we already tried that and that doesn't work. If we go back to only giving testing, only treating, giving vaccine to babies whose moms are positive and not giving to the other babies, then we're going to go back to seeing thousands of cases. And again, babies may be completely asymptomatic. We may not see that, but they will have chronic infection and eventually will have to deal with those. This is as far as you can get, I would say, right? Basically, checking your perinatal hepatitis B, and if you have someone who fails and has surface antigen positive, then that is chronic hepatitis B. This is for us, for ID or GI, if they are having liver failure. So I'll give you a brief tour about what we do, but I don't think you want to do this. I think at this point you want to, for discussion of how to test and how to interpret the testing, we can talk over the phone, we can deal with that. But once you detect someone who is surface antigen positive baby, and that remains positive for 6 months, that is chronic hepatitis B, that baby needs to be seen by us. Those babies go through 4 phases. The first one is the immune tolerant, which means that when the baby is born, their liver is perfectly fine, the LFTs are completely normal, but their level of viremia is in the millions. So they have tons of virus, but their body is not responding, and they're perfectly fine. Because again, the toxicity is due to the immune response, not to the presence of the virus. They're very contagious if through blood and some secretions, but other than that, they're perfectly happy babies. Then at some point during adolescence, they go to the second phase, which is the phase of immune activation, when their body starts responding and the LFTs starts going up and the viral DNA starts going down, but then their liver test also starts going up. So they start to having liver damage. If they remain damaged, the liver, there's elevated LFTs for more than 6 months, then and their DNA level remains high, then that's a moment when they may need to be treated. Many of them may not get to that point, and they may reverse before they damage the liver much, and they go to the inactive chronic hepatitis B, which goes until they're like 40 or 50 years when they have, and a lot of moms who come to us to have babies, that's what they are. They have surface antigen positive, they're even E antigen positive, but their liver is okay. They don't have any symptoms. They don't even know that they have chronic hepatitis B. That's the inactive chronic hepatitis B. But usually after age 40 or 50, again, their body starts responding to the presence of the virus, the LFTs starts going up, and then that's when they go into the real bad complications of hepatitis B. So we in pediatrics normally see phase 1, and in adolescents sometimes phase 2, and usually don't get any more than that, but we need to be cautious in case we need to treat those patients, right? Treatment of hepatitis B, there are medicines that are good. I'm afraid they don't cure hepatitis B. They only suppress hepatitis B. So we have to decide who to treat, and there's some guidelines out there that, again, probably we should be talking about, not you, and to decide when to treat. There's some very good medications. Tenofovir happens to be the one that I use all the time, and is very safe, it's very well tolerated. The problem is that it's for life. Basically, once you commit this kid to hepatitis B treatment, that's it. There's no stopping. That's why you don't want to start unless you have a good reason, right? And that's the problem. Sometimes don't do that mistake that you have someone is surface antigen positive and you start them on treatment and then send them over to us. And they already started on treatment. And now it's hard to stop the treatment. And the child may be stuck with treatment when maybe a little extra observation may have allow you to not to treat now and wait until further out. For infection control, the main thing is giving the vaccine. So if someone has not been vaccinated, let's say it's a household and someone has hepatitis B and the rest of the family has not been vaccinated, just vaccinate them. There's nothing else you can offer. In terms of precautions, it's a standard precautions. If they get admitted, if they go to daycare, there's no reason for them not to go unless they're aggressive babies who are, bleeding and biting others. But in general, there's no reason for them not to have a normal life. Secretions and blood precautions is important, especially in the household environment, not so much in regular schools. And breastfeeding is okay, right? For all hepatitis, if breastfeeding is fine. So if a mom has hepatitis B, she can breastfeed. There's no problem with that. So that was hepatitis B. Let's move quickly to hepatitis A and hepatitis C. Hepatitis A is an RNA virus. Hepatitis B was a DNA virus. It was a completely different thing, right? Hepatitis A causes only acute infection. There's no chronic form of acute hepatitis A. Occasionally can be very bad and can lead to liver failure. So it's not something to laugh about, but it's only acute. So there's no chronic hepatitis A. It's different in children versus adults in the sense that children tend to go asymptomatic while adults are very symptomatic with hepatitis A. But again, so children tend to be the ones who get infected, who transmit that fecal oral, so they start shedding it like crazy and contaminate the household or the daycare. But the adults are the ones who get sick, right? So before the vaccine, so anyone who's been in practice more than 30 years or so may remember how this was a problem with everyday care, right? Sooner or later, someone would call because the adults would get sick. And then when you check, you realize that all kids are infected in that daycare, even though they're not having symptoms, the adults are having symptoms. And this is the one who tends to come, because it's transmitted fecal oral, and you know how good babies are with this, then it comes in outbreaks, right? Hepatitis B, hepatitis C, there's some focal outbreaks, but if these rules about vaccination get relaxed too much, hepatitis A is the first one you're going to start seeing. We don't see it now because every children we see has been vaccinated with hepatitis A. So it has completely disappeared to us. It still happens on the adult world. They see hepatitis A from cohorts who have never received the vaccine. But if we stop using the vaccine, then quickly, this is the one of the hepatitis, this is the one that we're going to start seeing first. We have a vaccine, was developed sort of like a decade later than hepatitis A, so this is more like the 80s than 90s, right? It's very safe, very effective. It's given us 2 doses. starting at 1 year. So this is not perinatal infection. This is more household exposure or exposure to other kids. That's why you don't need to do it in the first year of life, the vaccine, plus the presence of maternal antibodies, which are common. Uh, don't let the vaccine to work too well. That's why we wait until they're 12 months. And then 6 to 12 months apart, we give 2 doses, and then they're protected for life. And this vaccine is like 100% effective. This is one of the best vaccines we ever came up with. On the right, there's a graph that shows you how much we had before. It was more like 20, 30,000 cases of hepatitis B before vaccine, and how little we have now. The use of the vaccine in pediatric population alone, not even touching the adults yet, but just in pediatric population, has decreased 20 times, so 95% the amount of hepatitis A that happens in the community. Again, not in children, but in adults. Even the adults are getting the benefit of children being vaccinated against this. If we don't do that, then we're going back to the left side of the graph instead of being on the right side of the graph. And that's going to be quite a challenge. We started immunizing high-risk areas in 1996, but again, as I said, that never works. So in 2006, they moved to universal, and all of a sudden, hepatitis A has gone from the pediatric textbooks. On the adult side, routine, by the way, hepatitis B is recommended for adults up to 60 years of age, even though a lot of adults have not had that vaccine. Hepatitis A is not recommended, but it's allowed for those who have additional risk factors. As I said before, I don't believe in high risk factors. I think one day they should just get away with this and vaccinate everyone. Is the only way to stop it. But this is the list of people that you would consider as at risk for bad hepatitis, and then you would give them hepatitis A vaccine, right? Anyone with chronic liver disease, I would throw in diabetes too here, people who use drugs, who get homeless, people traveling to endemic areas, those who are in close contact with international adoptees or refugees. Some people adopt patients for children from abroad. First thing is they all should get hepatitis A vaccine. Men who have sex with men and risk for occupational exposure. As you can go over the list, you can see how some of this may not be that easy to elicit. I mean, some patients may not tell you. I mean, these are some personal questions that some patients may not want to answer. So detecting people at high risk is not as easy as it sounds. For testing, it's much simpler than hepatitis B. Here you have hepatitis A IgM and hepatitis A total. There is a hepatitis A IgG, but I could not find it in our system. What we have is total and IgM. And similar to the core antibody that I mentioned before, the total would be IgG plus IgM. So if your total is positive and your IgM is negative, means that you have only IgG, you're protected. If your total is positive and your IgM is positive, means that you do have acute hepatitis A, right? And there is a PCR, but no one uses it. Not we in ID use it. We always go just by hepatitis A total and hepatitis A IgM. For treatment, there's no treatment for hepatitis A. Adolescents and adults who get sick can be sick for a month, 2 months, 3 months, can be really bad. Difficult to treat, and they're throwing up and they're not eating well and they're not feeling well for a long time. But management is only supportive, right? They can eat as much as they want to eat if they tolerate that. There's a study done way back in the 50s, the 60s, or even earlier than that, that showed that resting doesn't make a difference, right? So if someone is already feeling better and wants to go back to work or go back to playing basketball or whatever, they can do that. There's no reason to keep them assuming that doing exercise will make their hepatitis A any worse. And there's no antivirals, right? On the right side is control, right? What you would do in case of an outbreak, right? And your main thing should be try to get everyone who's not been immunized, get the vaccine, right? There's a thing called immune globulin IM, IgIM. It's similar to the IVIG, but this is the IM formulation, and it can be used for control of hepatitis A. But it should be reserved only to those who cannot take the vaccine. If some people just don't want to take the vaccine, why would they take the immune globulin and not the vaccine? That I don't know. Or if someone is immune compromised and would not have a good vaccine response, or if someone is less than 12 months, so does not qualify for the immune globulin, I'm sorry, for the vaccine, then you would keep the immune globulin, right? But other than that, always try to give the vaccine, because that would not only protect them, if given within 2 weeks of the exposure, it would not only protect them now, but would protect them forever, instead of the immune globulin, which after a month or two, the effectiveness is gone. And then hygienic measures, again, it comes in the stools. So that's what people who, if it's a baby in diapers, people who change should, the diaper should wash their hands well. If it's someone who's fecally continent, then an older kid, then they should wash their hands well after they use the restroom, right? Infectiousness is tricky, because actually the people are more infected 2 weeks before getting the jaundice, before getting the symptoms. So usually by the time you see someone, the horse is out of the barn. I mean, it's already out there. And then they're infectious for 1 week. So little kids in diapers or people hospitalized for acute hepatitis may need to be on isolation for a week. But after that, even though they may still be feeling crappy and they may still have jaundice and all that, yeah, they're not contagious anymore. They stop shedding the virus. It's just that they're fighting the virus inside them. And all this, by the way, A, B, and C should be reported to the Department of Health. It's the only way to know what's going on and try to improve measures to stop this from getting out of hand. And finally, I want to talk a little about hepatitis C. Hepatitis C is not vaccine preventable. I wish we had a vaccine, but we don't. But because A and B has been so well controlled for 3-4 decades, actually C is the main problem these days. Of course, if A and B make a comeback, we're going to stop talking about C. Again, not because it's gone away, simply because it's being obscured by how much of the others we may see. But at this moment, hepatitis C is actually the main cause of acute hepatitis in adolescents and adults, especially those who share needles. And the main thing is that it's treatable, as opposed to A or B. This one you can treat. This one you can make a huge difference. And that's why I want to make sure you guys understand that. This is an RNA virus, again, different than A and B. It tends to be very indolent, right? Hepatitis A and even hepatitis B give you LFTs in the thousands levels, 1,000, 1,500, 2,000, very high levels, right? Hepatitis C tends to go much lower, 100, 200, 300, 500 is probably on the upper limit of hepatitis C, rarely to give more than that. And they don't have that many symptoms, right? But a lot of them go chronic. While hepatitis B, adults with symptoms, only 5-10% get chronic. Hepatitis C, about 80%, 60-80% become chronic. So most people who get acute hepatitis C will go into chronic hepatitis. And that's why hepatitis C is actually the main reason for liver transplants in the US. And it's not too different between children and adults, right? Hepatitis B and hepatitis A tend to be different between children and adults. Hepatitis C, if you catch it, you probably, again, not going to have too many symptoms, but it's going to stay with you and it's going to go into chronic liver disease eventually. This one is very dependent on blood transmission, right? Hepatitis B was blood and other secretions, vaginal secretions, and even saliva, etc. Hepatitis C is basically blood only. So unless you're sharing needles, you're getting exposed to blood, hepatitis C is a no-no. But that's something that happens when babies are born. So perinatal transmission happens, and that's what our main concern is. The diagnosis is not too difficult. We have only hepatitis C antibody, no IgG, IgM, just antibody, right? And if that is positive, then you have to follow with RNA, right? Some people, those who cleared the infection, have antibody positive, but RNA negative. Those who keep the infection, which is most of them, will have antibody positive and then RNA positive. RNA positive means you are chronically infected with hepatitis C. So the situation we see more often is perinatal exposure of hepatitis C. So talk a little bit about that. Because of this, all moms are checked for hepatitis C antibody. If they're negative, that's fine. If they're positive, then they do a hepatitis C RNA, right? And if it's positive, means mom is chronically infected, the baby is going to be exposed. Different to hepatitis B, there's no maternal treatment here. You just wait to see what happens. Fortunately, the risk of transmission to the baby is much lower than chronic hepatitis B. Chronic hepatitis B is 90%, for hepatitis C is only 5%. That's why we don't do much, because 95% of kids probably are going to be okay, spare the infection. And there's no vaccine or immune globulin to offer to the baby. You don't do nothing to the baby, you just wait. And then you test the baby with the RNA when the baby is 2 to 6 months, right? Takes about a month for the RNA on baby who are infected to show. The decision to recommend 2 to 6 months is because that's the age when you probably are going to be seeing these babies for the follow-up. So whenever you see the baby within this period, 2 to 6 months, then send for an RNA, hepatitis C RNA on the baby. If it's positive, the baby is infected, we need to know about that. If it's negative, then the baby is not infected, and that's the end of the story. You don't need to do anymore. In the not so distant past, we used to wait until the baby was 18 months and do an antibody when we didn't have the RNA, because that's how long it takes for the maternal antibodies to go away. So don't do it under 18 months of age, right? So we waited until the baby was 18 months or 2 years and then do an antibody. If antibody positive, the baby is infected. If antibody negative, the baby is not infected. Now that we have the RNA, we don't have to do that. Now, that said, a disclaimer is I feel better if the family doesn't mind is doing the RNA at 2 to 6 months and then doing the antibody at 18 months, so I can guarantee them that there is no chance the baby is infected, right? Which is, again, high chance, right? 95% they're not going to be infected, only 5% that they will be infected. The problem is if the RNA is positive, which will happen 5%, so 1 out of 20. By the way, at Kapiolani, we see about 40 moms with hepatitis B a year and about 4 moms with hepatitis C a year. So that's the kind of number that we deal with. 10 times more frequent to see hepatitis B. Fortunately, we have a lot of interventions and we prevent a lot of infection transmission. Hepatitis C is less frequent, but there's not much we can do to intervene. If the baby is RNA positive, then there's no intervention for the first 3 years. One is the baby is going to look perfectly fine. It's going to be growing, happy, and whatever. Actually, these babies don't even get ear infections. It's amazing how well they do. For some reason, they do great. And they have a chance, maybe 30, 40% during the first 3 years that they may clear the infection spontaneously. So we just see them every 6 months. We check the RNA, we check the LFTs. If everything is fine, we just see them again and again and again until 3 years. But after 3 years, then the chances of clearing the infection are very low. So that's when we consider treatment. I normally repeat the profile at 3.5 years to make sure that, yeah, you pass the 3 years, not just at 3 years, but at 3.5 years, and you still are positive and everything else. Okay, then we talk about treatment. The good thing is that they're excellent treatment. They're combination treatments. We're not going to go into the details about what they are and whatever. Again, I don't think you want to do this. This we are doing. You send them to ID, we'll deal with the positive babies. But the treatment is oral treatment with medications for 12 weeks, and there's pediatric formulations for at least 2 of those medications. And you need prior approval, but usually they get approved once you show them that indeed the baby has a positive RNA. And give them the medicine for 12 weeks. Family needs to understand there's no urgency in treating, and once you start the treatment, you don't want to stop. So if there's something going on in the family, they're moving to a different house, or mom is changing jobs, or they're moving, whatever reason that their life is not too stable now, then let's wait. And once everything is okay, then for the next 12 weeks, make sure someone is going to be giving this baby the medicine religiously every day. It's very easy to give. I think it's once a day. And for the 12 weeks, 3 months, we normally do a PCR before starting the treatment, 1 month into treatment. If the PCR, which is usually negative, just 1 month into treatment, then we complete the 3 months of treatment. We repeat the PCR at the end of treatment to make sure they remain negative, and then 3 months after treatment, after completion of treatment, so no treatment, 3 months later, we repeat the PCR. If that one is negative, that means that the baby is cured. It's cured from hepatitis C. And I emphasize this because hepatitis B, as much as we have rules and we have interventions and vaccines and immune globulins and so on, we cannot treat, we cannot cure, we can only control. While hepatitis C, we can cure. And the efficacy of the treatment is literally 100%. It's rarely. Something has to go wrong, like they stopped the treatment or they didn't absorb it well or something for someone to fail therapy. So this is something we can really completely cure. Again, it's mostly for us in ID to take care of this. Your job is to test them, to detect them, test them at 2 to 6 months, and if they're positive, then just send them over to us. If you are away, outer island, and it's hard for you, for the family to come here, we can always talk over the phone and go over the details about exactly how to do this. I usually see them one time, order the prescription, explain them everything they need to do, and I manage them wherever they come from. They can go back to their community and just do the treatment, and then only come back to get retested or something like that. But it's not like they have to come in back every week or something like that. And with the treatment, then the RNA should disappear, but the antibody will be positive for life, right? You need to know that hepatitis C, hepatitis B also, they don't immunize you. If you have hepatitis C, then you can get a new infection in the future. You have hepatitis B, unless you develop surface antibody, you can get reinfected and so on. So these babies, I normally give them a letter saying that, yeah, the antibody will always be positive. So these are babies who, if in the future they need to be tested for any reason for hepatitis C, they should not do the antibody. Or if the antibody is positive, they should not freak out because that is expected. What they should do is move on and do the RNA because that's the only one who proves if they're really newly infected or not. Adolescents with HCV, again, if they're involved with blood needle exchange, needle sharing, then if they have, they can get infected. If they have hepatitis C antibody positive, then please check the RNA to know if they are actually infected or if they cleared the infection, which again, most of them will remain infected, and then do an ALT to know how bad the liver is. Hopefully not too bad. Hopefully this is something new. If the HCV RNA is elevated, means that they are infected. You repeat that in 6 months because that's the definition of chronic hepatitis. If they clear within the next 6 months, then they are among the 30% or so, 40% that may clear the infection. But if not, then they are chronically infected, and then you need to treat, right? And again, same treatment. There's actually more options for adolescents and adults than for babies, but they all perfectly completely effective medications. And these adolescents, if they have not been immunized against A and B, immunize them because the last thing you want is to catch another hepatitis on top of the hepatitis that you already have. And they should avoid alcohol and any hepatotoxic medications. Tylenol, by the way, is fine. Sometimes they get scared that not even Tylenol. No, that's not okay. Tylenol at therapeutic doses is fine for any of these hepatitis. They can still do that. And for infection control, well, yeah, for hepatitis C, it's a standard precaution. They can go to daycare. These babies, there's no reason not to. They can live at home and they can do their regular things. And adolescents, again, as long as they can also, as long as they don't share needles, that they should be okay. Blood precautions is the main thing. And one more time, if mom is hepatitis C, she can still breastfeed the baby, right? And again, summary, well, I don't need to repeat everything that I already said. And again, there's not much structure on this because we should not even be talking about this. The main thing is, yeah, be alert, because if there's more relaxing on the immunization of our community, then we're going to start seeing some of these cases. If you have someone who seems to have hepatitis, then immediately test. And if they're positive, then call us or send them over to us, and we'll talk about what to do with them. And acute cases, especially, they should be reported to the Department of Health. It doesn't hurt to call them anyway and tell them, this is what I'm seeing. Is this something you need to know about? Is this something you need to get involved with? And many times they do, because if there's an outbreak, especially in outer islands, they need to go and they need to investigate what's going on there that is causing that outbreak. And with that, I think I'll stop here in case someone has a question or a comment.